It has been a privilege and a pleasure to work throughout the year with Beth and, of course, the team, Heidi and now Tina, in this leadership role and making this Nurse Tech Symposium, which started right in 1998. So 22nd, right on the first day, we said it has to be Nurse Tech Symposium, and this is what has evolved to more than 60% of the house full. And what I'll do is, if that next 27, 28 minutes, we got 2 minutes were wasted in taking the flag one side, the talk about the top 10 advances. There are a lot of them, but the whole purpose will be to give you the concept that what is happening in our field. I always start my lecture with giving tributes to one person because of whom we are here, and that is Andreas Grundtvig. He's the one who invented the balloon angioplasty. And then, of course, now we have gone to this various levels. With that, his dream then was the catheter-based percutaneous treatment of vascular disease in alert and awake patient. And of course, I put with utmost safety, that my quotation. So key is that he was the inventor. Back then, he died in 1984 in the plane crash. And he didn't see what is now. The majority of the procedures, whether it's a percutaneous aortic valve replacement, the mitrals, and so, besides having PCI, are being done as an outpatient basis. Although tower still remain 1 to 2 nights stay in the hospital, but some cases can safely be discharged, but purpose will remain that how can you make these procedures ambulatory. So key is, what I'm going to show you today, that 2018, which change our clinical practice, what were the major publications in that year. So now, start with a recurrent DES ISR. What does that mean? The DES are good. That's what we do. Decrease restenosis, but they also reblock. So question is, what are the various treatment for it? And the various factors why the stent reblock, because intimal hyperplasia, stent not done correctly, and dissections, many of them. And various treatments which are done, you do a balloon angioplasty, you do a drug-coated balloon, or another DES. So these various techniques have, over the years, have been used to treat the DES ISR, and of course, you can always send patients for bypass surgery. But these are the various techniques here. The two most common, actually, is the drug-coated balloon. That is, not the drug-eluting stent, but drug-coated balloon. So same, the paclitaxel drug, which used to be on the paclitaxel stent, is on the balloon, and it, by the special mechanism, stays in the, when the balloon inflates, it stays in the vessel wall. So this was the trial comparing drug-eluting balloon versus everolimus eluting stent. That is our Zions stent in 270 patients, and basically showed the similar outcome. So key is, once you have DES ISR, the drug-eluting balloon are equally good, and you don't need to put a second stent. Then question was, does it do better if you do a cutting balloon before putting that drug-eluting balloon? Because so that the drug can go inside the vessel wall. And this was the trial. To answer that question, I said desire 4 is scoring balloon plus drug-eluting balloon, or just a regular balloon followed by drug-eluting balloon. And you see here, the event rate with a scoring balloon was non-statistically lower compared to control. So it seems to be a little trend, but not clear-cut overall benefit. Then radiation. Those who are in this field probably know we used to do quite a bit of intravascular brachytherapy back in early days of before 2002, 2003. Cypher and Texas came because the treatment for BMS, one of the used to be the brachytherapy. Then we did multiple trials comparing brachytherapy with the drug-eluting stents of the Texas and Cypher, and all came, the DES came superior to brachytherapy, which disappeared. But now we have DES, restenosis, you put another DES, patient comes back, what to do? So this has taken the second wind. We started this program in 2012, the third in the country, and now there are 52 centers doing the brachytherapy. We do still highest, about 100 plus per year, and we presented our data, published last year in a prestigious journal, Circulation Cardiovascular Intervention, and these are the patients, all have at least more than 2 layers of drug-eluting stent. So already you have 2 layers. You want to put a third layer, and what did we find? By doing a brachytherapy, you decrease the event rate from 46% to 18%. and there was no thrombosis because we continue antiplatelet therapy for 3 years, and there was no restenting. No restenting. Now this program, this was about 200 patients. Now we are almost 400 plus, and we'll give publish the long-term follow-up of these patients. And these are the individual endpoints. So what we do, large vessel, based on the data, you can use a drug coated balloon or drug-eluting balloon. Read-DES, particularly in the, smaller vessel, drug-eluting balloon. In the large vessel, you use Read-DES with the everluminous eluting stent, and patients with more than 2 layers of stent should get IBBT. Second, calcific lesion, always a trouble, and there are various trials because calcific lesion is shown here by the angio, by the IVUS, and by OCT. You can identify. These lesions do very poorly because of various issues, because you can't get the stent would not expand, and of course there are dissection, malapposition, and various factors. So we have various devices to deal with it. Usually there are orbital or rotational atherectomy once you have severely calcific lesion, and the one trial which was presented last year comparing just the scoring balloon, like our cutting balloon, or rotational atherectomy before stenting. It was our zero stent, and these are the two devices used, and basically found that by using the rotational atherectomy, if you don't use the rotablation, in 16% of cases, if you try to do only cutting balloon, you'll not be able to deliver the device. So 16% was crossover, needed to do rotational atherectomy. What was the overall outcome? Overall outcome, because a small trial of 200 patients, was favored rotational atherectomy, the height of the green bar. It did not make a statistical significance because small number. But key overall message was that calcific lesion, you need to do atherectomy, rotational atherectomy. This is like follow-up of the Rotexas trial, which these investigators did about 5 years ago. Now, we actually published our data that all of the rotational or orbital, which one is better. This is about 1,150 patients, consecutive patients, and we basically found that we have a lower complication with rotational atherectomy in terms of dissection and perforation. Others were not different, but these perforation occur with the orbital because in the beginning, we are using 120,000 RPM. So once you use 80,000, it does not happen. And overall outcome point of view at a follow-up, actually, orbital atherectomy patients did better compared to rotational atherectomy. So key is that, yes, both techniques are here, and we actually have published that which case you should use rotational or which case you should use orbital atherectomy. Then imaging study to improve our overall outcome. There are many trials, particularly angiography, the NEARS, which tells you the yellow of the plaque. Actually, Dr. Keeney has published a lot of data on the yellow trial, but this device has been removed from the market now. The IVUS, and more sophisticated IVUS is the OCT, with 10 times better resolution. And we have various criteria, what is the lumen for which you should be putting a stent or you should defer the PCI. And then came the physiological testing of the IFR and FFR, which by giving adenosine, and you see the gradient, and if it is less than 0.8, various trials have shown the better outcome with the FFR-guided PCI. So what happened is, in the last year, there are many data published. This is the data from the London. 12% patient got the IVUS, 1.3 got the OCT, remaining have PCI done by just angiography, and basically showed angiography, IVUS, and OCT that your outcome, but in hospital MACE as well as death, was lower with the imaging-guided PCI. More importantly, at follow-up, if you do imaging, particularly OCT-guided PCI, 7.7% event at 5 years compared to 15% with angiography. So overall, seems to be that imaging-guided PCI is better. But these are the registry data. You need a randomized trial. And there was a trial called Ultimate, which is the randomized trial of 1,400 patients. All patients were done IVUS guidance or angiography guidance with a 12-month period endpoint. Basically, that by doing the IVUS, you increase the lumen better. You're able to expand the stent, although it takes a little more procedure time and a little more dye. But outcome was event rate of 5.4 on the angiography goes down to half, 2.9%. So seems to be the routine use of ultrasound was associated with the lower event rate. Now, ultimate answer for the OCT will be the trial. Our fellow Ziad, who is doing a great job at present at Columbia, leading this trial of 2,500 patients. OCT-guided PCI, complex cases compared to angio-guided PCI. With a 1-year follow-up will be the answer. Will take about 2 years, but will really establish that using the imaging during PCI, can you improve the outcomes? Now, what continues to be the FFR, now we have the 5-year data of the FAME2 trial. It continues to show that FFR-guided PCI have a lower event rate compared to just medical therapy. So FFR is in our, you can say, in the blood. So 60–70% of PCIs are done with the FFR guidance at Mount Sinai Medical Center. So then bifurcation lesion, that is the lesion at the branch point. There are various techniques, what to do. There are numerous algorithms, and you can see here the techniques which have been published, what type, where it should be. So what Dr. Keeney and us, we did together, came up with because this is the era of the app technology. You have app for everything. You take which way you should go. You take a deep breath or not deep breath. You can guide by the app. And this actually made with a left main or non-left main, and where the blockage is, to make it really user-friendly, that can it be an educational tool. And I'll tell you through this case. This is a bifurcation case of the distal left main. And then what you can do is that, and that we are done. The app, this is the pictures in the app. Now here, bifurcation, you're doing a balloon, and then you go next, you put a stent in the side branch, inflate, take the wire out, and then of course you balloon on the main vessel, put another stent. So side by side, what exactly we are doing in an angiogram is shown on the app, and very interesting, and then final kissing dilatation with excellent results. So it's a great teaching tool which is both for app as well as the Android. This was published because of the educational mission. Dr. Fuchser published this, Global Cardiovascular Education, in JAC last year, and we went through this all phases, that how we developed this 10-phase in the development of this app, which has been downloaded by 10,000 plus people globally. So it is a very good educational tool which people use at present. Then the newer DES and the drug-coated balloon trial. So one of the stent actually was was big news last year in TCT, Talent trial. This was a ultra-thin strut bioresorbable polymer stent made in India, Supraflex, SES, which is a sirolimus small concentration, biodegradable polymer, and the Supraflex SES was tested against our best Xience stent. So what they found basically is, from the efficacy point of view, Xience did better. Lower profile, device success was better. Now, at follow-up of these 1,500 patients, overall outcome was identical. So just to say, another stent, and the big advantage of this stent will be half the price. So they are actually, this approved in, at present, they got the CE mark approval. They're selling it in India, in Europe, and South America, and hopefully soon come to America also. And the price, usually now we pay for the stent around $800, $850. This will be a $400 stent. Cut the price. So this is the key. Anything made in India will be very cheap, but very effective. All right. Then the drug-coated balloon, the small arteries. Because small arteries, you can put a stent, but not a great data. The various techniques have been used. So what was the trial was the basket small 2, which compared the drug-coated balloon versus DES, although 25% was the old Texas stent. And basically they found that overall outcome, myocardial infarction, target, the blue is a drug-eluting stent paclitaxel, red is a drug-coated balloon that you can see. Numerically lower, but no difference, although there was slightly signal of higher death rate, but was not a p-value significant. Just to sum it up, the drug-coated balloon was non-inferior to DS in a small vessel. You don't want to put a stent in the small vessels unless it is necessary. Then the senior trial in the elderly patients more than 75 years of age, cut duration of the depth by using the synergy stent versus bare metal stent, 1 to 6 months, and basically showed the DS versus bare metal, but the DES getting the depth for 1 to 6 months. 1 month in stable patient, 6 months in unstable patient. And you can see here, compared to bare metal stent, lower event rate. So it makes sense now that there's no reason to use a bare metal stent. You worry about long-term antiplatelet, you can stop after 1 month. There are many trials ongoing at present to really abbreviate the depth duration to 1 month and so. Then PCI versus Cabbage, 5-year plus. We have few trials. So basically we know a 5-year in the complex PCI, complex CAD, Cabbage do better than PCI. And this actually has been shown. Cabbage has its own plus point, PCI has its own plus point. Biggest thing is a short recovery time, lower length of stay, and the lower CVA rate. Cabbage, more durable. So we have the data up to 5 years. Question is, what happens after 5 years? Now we have actually data up to 10 years by the 4 trials. Lehman's, Freedom, Syntaxis, and Main Compare, all published in 2018. The Lehman's trial was the 200-patient trial, showed that by doing PCI compared to Cabbage, you have a better ejection fraction at follow-up. It was a small trial, so overall, but event rate in this group of patients, it was done in South America, not a good PCI, the Cabbage results. Why? Because the Lima was used in only 2/3 of cases. But overall, it shows that 10-year Cabbage and PCI were okay. Then Freedom follow-on, right from Mount Sinai. We have a 5-year data before. Now we have 8 to 10-year data. Follow-up of these patients basically showed that, yes, the Cabbage continued to do better compared to PCI even after 5 years. Because people used to say, well, graft will close after 6-7 years and PCI will be better. Well, to our disappointment, not true. I didn't like to say that, but that's the fact. That the Cabbage, now, what will happen after 10 years? We'll see. But definitely 10 years is that we still Cabbage continue to do better. Then Syntax trial, which made these both, Freedom and Syntax, made the guidelines. So Syntax trial was the original with the high Syntax score, do Cabbage better, low Syntax PCI. And this is the same, the 5-year data initially, PCI and Cabbage. Clearly the Cabbage have a lower mortality and the MACI compared to PCI. And now at 10-year data, which was presented, is still the same thing. The Cabbage, mortality 25%, PCI 5% over. The Cabbage in all group patients, 3-vessel disease more, difference compared to only left main. And then if you take a high Syntax score patient, that's where the benefit comes of the Cabbage. So what we knew in 5 years of the Syntax, same message came for the 10 years. So it seems to be Cabbage continues to be superior in more advanced disease, high Syntax score patients, even at 10 years. So clearly we decide based on the PCI, or whether we select PCI or the Cabbage, the most important is the hard team discussion. And then tailor-made the approach. Now, one thing is what happens in real life compared to these trials. Even if you recommend the patient Cabbage, and this is what we do very rigorously, and this is part of our quality initiative of the cath lab. So complex cases, get the hard team discussion, and 50% of the time, and you are not having a discussion while patient on the cath table, the outside, 50% patient will refuse. Then we'll go for PCI. But that is okay. But that is the part of the hard team discussion. Because patient says, well, as long as I can come back and few times, restenosis, and so that's okay. But key is, you have to come up with a strategy, present to the patient in a controlled environment, and then do the right thing what patient wants. Then radial intervention, lot of data have been on the radial. Pro-radial, the whole country is moving towards now. About 42% in the United States, interventions are done radial, while many countries, 80-90%. The Matrix trial was 1-year data, which showed comparing radial versus femoral, or bivalvular versus heparin, and basically showed that at 1 year, the radial have a lower cumulative incidence of net adverse cardiac event, that is a bleeding minus MACE. So clearly the radial is superior to femoral artery, and these are the individual endpoint of the cardiovascular death. Stroke, no more stroke now with the newer techniques of the radial interventions, I would say, and definitely the lower bleeding. So clearly radial continues to evolve. We also set our goal of 40%, of radial interventions Mount Sinai, which we exceeded last year. This year we have a goal of 50%, and we are about 43 so far. Let's see where we will be by year end. And that actually definitely has reduced our vascular complication. In the state report, we are always lower in every other complication, but the vascular complication used to be high. By crossing this 40% threshold number, our vascular complication now became half of the New York State. Now, antithrombin, unfractionated versus bivalvulotin, basically no difference. So clearly, PCI now, almost half are done with the heparin, half with the bivalvulotin, and of course, radial has taken in Europe at a class 1 indication, although in United States still remain 2A. Then, multivessel PCI and cardiogenic shock. You were taught is that if you have cardiogenic shock, open every vessel possible. And there was a trial done to do the culprit vessel versus the all-vessel PCI, and basically endpoint of mortality and renal replacement therapy showed that culprit vessel versus the multi-vessel PCI, culprit vessel was better compared to multi-vessel. Totally eye-opener, totally nobody expected that. Because we are always taught cardiogenic shock, you open every vessel. Now, in STEMI also, we have done so many trials now to do a complete revascularization. Now, this has gone to other side. That is, by doing the full revascularization was bad in patient with the cardiogenic shock, and these are the individual endpoints, and show basically what it did is it changed the guidelines already in Europe. We are a little far behind, that now cardiogenic shock multi-vessel PCI became inappropriate, class 3. So although United States have not changed the guidelines yet, but key is this is going to have big impact. The second in the field of STEMI is the door to unloading. What is unloading means? That before you open the vessel, if you can decrease the ventricular size and cavity, maybe your perfusion will be better, microvascular perfusion, myocardial recovery will be better. Although concept is you are putting an impala, wait for half hour before you open the vessel. Everybody felt it's crazy. We are teaching the entire country, door to balloon time, open the artery quickly. How can you wait half hour? But it was substantiated by a lot of animal data and preclinical work. And this led to the pilot study of the immediate revascularization versus delayed revascularization after 30 minutes of unloading, and it showed the concept was okay. So infarct size was slightly lower with the delayed versus immediate. So this actually had led to now the major trial, and we'll be part of it, which is going to look at the concept that patient comes in, you get the impala CP, and unload the ventricle for 30 minutes and then do the PCI. Versus you do immediate door to balloon time quick PCI. So whether this will be successful or not need to be seen, but the trial is going to start by next month. And Mount Sinai will be one of the center for this trial. All these patients are anterior wall MI. Then inflammation post PCI. So what is inflammation? So basically, that besides only thing we have been taught is the lipids, is the cholesterol that kills the people, blockage, rupture, MI, and all this. But it's something beyond that. And what has happened is one of the common parameter which you can measure is the CRP. So there is a lot science behind these cytokines, which contribute and released at the cellular level in the endothelium, in the vessel wall, and responsible for cardiac events. Your LDL may be 70 or 50, but patient is still coming back cardiac event. Why? Because the vessel is inflamed. So this field actually is evolving in last few years. And you see at every level, there are many drugs which are being tested to see effectiveness or failure. So 2 of them already have come to the published in NEJM. Cantos, by using this very complex name, canalicurim, I can't even pronounce it. It's the interleukin 1B inhibition, but showed better by reducing the inflammation. Second was they did a methotrexate, with their trial failed. The third trial of the colchicine is ongoing, and many other agents at present. So what we did is, from Mount Sinai database, Dr. Mehran, very smartly, that what if, let's see, that we do a great job in the PCI, and you see it very great results, lower 30-day risk-adjusted mortality compared to any part in the New York State. So can we find some predictor based on this inflammation that correlate with subsequent outcome? So what they did is, we have the CRP. As a part of the PCI, we check the CRPs. So they took the patients who had two values of CRP more than 4 weeks apart. And high CRP identified was called as a 2 milligram per liter. So you have persistent high CRP at the time of PCI and the second value. Second was increase, and basically what we call residual inflammatory risk means your CRP was elevated. Residual inflammatory risk means CRP was more than 2. Increased CRP, RIR means it was normal at the first level, second became more than 2. Third was attenuated, that it was the high before became low. And the fourth one, that was low throughout in the 2 values. So what we found, these are the various values, but very interestingly, you see here, persistent high, increase, then attenuated, and the persistent low. Great gradient, phenomenal. That clearly that CRP, simple test, tells you after having good angioplasty at 1 year follow-up, predictor of subsequent event, and you can see very well. So very nice central figure with a 1 year death, MI, MACE, and they published in European Heart Journal. Actually, European Heart Journal, from the cardiology point of view, is the top journal at present with the impact factor of 21.6. Used to be JACC at one point. JACC is about now 18, but European Heart Journal, phenomenal paper, right from the Mount Sinai database. So therefore, we don't only worry about the LDL only, but we need to worry about the inflammation. And there are a lot of drugs which are being investigated, and you'll hear more about them in the future. Then comes the last and most important advance of last year, I would say aspirin duration post-DES. So clearly we know that 3 to 6 months, you need to adapt because it's ischemic benefit. After 1 year, you probably not need because you have more bleeding. 3 to 6 months is the time period you decide, and so. So key remains that what we have done is that we abbreviated the depth for 3 to 30 months in many trials, but now we have 2 trials which are going to decrease the aspirin dose. Nobody think about the aspirin duration. They were all talking about the clopidogrel or the ticagrelor or any other prasugrel decrease, but nobody thought about aspirin as a culprit. And basically, major trial called Global Leaders, this is the patient, they did an aspirin for 1 month and continued ticagrelor for 24 months, and compared against your aspirin plus ticagrelor, which we usually give for 1 year, 1 and 2 years, and clopidogrel versus aspirin in stable patient, and basically with a 2-year follow-up of the death and new Q-wave MI at 1 year was beneficial, but after that, see that compliance rate decreased, but more importantly, 2-year endpoint, you can see here ticagrelor monotherapy was 2.8 versus 3.17, p-value was 0.18, missed the significance. But what it showed, that by eliminating aspirin, there is no more bleeding. So clearly the benefit from that point of view, and these are the individual endpoints, barely missed by p-value. Remember, anything less than 0.05 is significant. We were 0.07. But key, this actually everybody felt it was a negative trial. The interpretation was that ticagrelor in combination with aspirin for 1 month, followed by ticagrelor alone for 23 months, was not superior to 12 months of standard dual antiplatelet therapy, followed by 12 months of aspirin alone in the prevention of all-cause mortality or non-QA or new QAMI after 2 months of PCI. I take it in a different way, and my interpretation was a little more positive. That is, the global leaders have opened the door for future trials of eliminating aspirin after short time post-PCI to decrease bleeding without affecting stent thrombosis. So at least we part done. Of course, we had to do some extra work. This is the Twilight, which is generated from Mount Sinai with the 3 months of aspirin, and then ticagrelor. The large trial of 9,000 patients has been completed and will be presented in TCT. That will be the real proof of concept. Although even the Twilight, I originally predicted even before the global leader that let's do it 1 month, but AstraZeneca didn't agree when Dr. Roxana Mehran met with the company executives. But anyway, 3 months. But key is the aspirin. As you know, the aspirin in the primary prevention, so many papers last year, no good. Whether you are diabetic, postmenopausal, patient with a primary prevention, aspirin actually causes more bleeding, maybe even some cases cancer. So aspirin actually as a primary prevention has gone down. With the secondary prevention may remain okay, but post-stenting with a stronger antiplatelet agent like ticagrelor, aspirin probably will have no role. So these are the top 10 advances. Purpose of them is, if I put it together, multivessel PCI in cardiogenic shock, bivalvulotin in PCI, FFR post-Cabbage, no good. Bivalvulotin, the bifurcate EP, rotational atherectomy in calcific lesion, Cabbage 5 to 10 years, plus ivermectin PCI, drug-coated balloon in small vessels, ISR, 1 month of aspirin ticagrelor, plus, and the real was the transradial PCI, IVBT, and residual inflammatory risk. Post PCI really taught us a lot of new things in this area to make us better interventionalists. And as Beth earlier showed, these are our data of the combined 3 years of 2014 and 16, highest volume. Double star means statistically lower mortality. And of course, 3 of us, you have seen in actually those who are at Sinai system, Sharma, Keeney, and Moreno with a double star, and for 21 year plus, Mount Sinai continue to be, whether the attending or the cath lab. And then of course, and also the statistically lower readmission. So what it has done with the good publicity, we actually, after a long time, we are having a good growth. Last 5 months, 17% growth in all aspects. PCI, endovascular intervention, structural, we actually, right now, we have 38 plus valve compared to last year and last 5 months. So clearly, we should have 100 plus, and this is still, once you get a low-risk approval and the functional mitral rigorous mitral clip, that number will, next year, we should have at least 200, 250 further. What really gives me the great pride, and I'm just going to conclude with my last 1 or 2 slides, that is the teaching, global education. Global is the word. Back in 2009, decided that how can we at Sinai, we do this symposium, a few hundred people are here, but how can you teach 10,000, 20,000 people globally sitting nowhere they are? And this we started. Next Tuesday will be the 120th episode, 10 years, continuous 8 to 9 CCC symposium, 3rd Tuesday of the month. And Samir Mehta comes to all, he's a moderator, and what it has done, look at this. Many times 18,000, average 12 to 15,000 people are watching the CCC live and becoming better in terms of their interventional cardiology. And this is where, and the various countries, actually United States is top, second is India. And then of course Germany and many others, 138 plus countries. And this I end with that, thousands of candles can be lighted from a single candle, and the life of the candle will not be shortened. Happiness and knowledge never decreases by being shared. Thank you very much.